We'd like to move on, and our next speaker will be Dr. Rohn Rigby. He also is from the Davis campus of the Ogden Clinic, and he'll be speaking on medical management, not just calories in versus calories out. He is board certified in both family medicine and obesity medicine. He enjoys working in a multidisciplined family practice clinic, and he has a special interest in obesity medicine, treating patients with comorbid conditions that are associated with obesity, such as diabetes, hypertension, osteoarthritis, hypothyroidism, and many others. Rigby himself struggled with weight issues until his late 30s. He understands the difficulty of losing excess pounds and maintaining a healthy weight. Through lifestyle changes that included healthy food, exercise, stress reduction, and proper sleep, he lost about 80 pounds and has kept it off for several years. He grew up with his dad in the Air Force. As a result, his family lived and traveled all over the world. In addition to these travels, he served a church mission to Seoul, South Korea, and he has been married for 23 years and has 4 children. He enjoys spending time with his family, running, biking, hiking, camping, and boating. Please join me in welcoming Dr. Rohn Rigby.
Well, thank you for this opportunity. Let's see if this works. Oops, did I go the wrong way? Did I screw it up already? Nope, I did. Oh yeah, let's see. Nope, nope, nope. What'd I do, guys? I walk up here and ruin it already. Oh yeah, let's see. I jokingly said I had to download it on my phone so I could at least read it to you guys, so I have that back up if I need it. Oh yeah, let's see. Let's see. Anything I can do up this part, or am I? Here we go. Can I advance it with this, or do I have to have you guys advance it? Okay. So I have nothing to disclose for this. We're going to talk about the medical management of obesity. As we all know, it's a growing problem that we deal with on a daily basis. In our offices, our patients come in asking for help, trying to figure out what to do. Next slide. We'll start with a case study. So we all like case studies. We see patients on a regular basis. A 38-year-old female, or excuse me, female, 38-year-old male comes in, or at least comes into the ER complaining of some chest pain. He has a strong family history of metabolic syndrome, hyperlipidemia, hypertension, obesity, sleep apnea, depression. The workup in the ER was all normal, therefore was sent home to kind of follow up with his family practice doctor and told to make lifestyle changes. He did start making some lifestyle changes, started to decrease his stress a little bit, started to get rest or sleep a little bit more, lost a little bit of weight with some modified dietary changes, increasing activity a little bit, dropped from about 250 down to about 110. Stayed there for a while, was still into the obese category by BMI standards, therefore was trying to figure out what he needed to do, therefore became a little bit more drastic and changed it to a low carbohydrate diet. Next slide. And as it was demonstrated, that's myself. I live it on a regular basis, so it can be done. So each of us who, if you're having issues or want to help your patients, there's lots of options to go for. Next slide. Oh, there's a definition of obesity. We all want to go by a certain definition. We can go by BMI standards, but there's a lot of different things that play a role in what is going on in our patients. It's not just because they're eating too much, and nobody wants to go out and do something to hurt themselves on a regular basis. There's a lot of factors that go into it, and this is the actual definition by the American Society of Bariatric Physicians. Next slide. So there's let's pull it up this way so I can remember everything on the slide. Amen. There we go. Here we go. So there's multiple factors that go into this disease: the genetics, the environment, the immune system, the medical aspect, and endocrine. So it's not just a one type of thing that goes into this, what causes the patient to get to that point in coming into your office. Next slide. So we're talking about it from multiple different aspects. So looking at the adipose tissue as its own system in itself, there's lots of functions going on. You've got the sick fat disease, how it interacts, and that kind of gets us into the metabolic syndrome. Most of us have heard of metabolic syndrome. A lot of different factors and multiple different ways of looking at it, but kind of the accepted way in the United States is you have to have 3 of 5 things to fit into that category. One, looking at waist circumference, and there's a difference between the males and the females. Females about 35 inches, males of 40. And then you've got an abnormal elevated blood pressure or on blood pressure medication. You've also got abnormal A1Cs or abnormal glucose tolerance tests or abnormal fasting glucose. So looking at how that insulin resistance that was being talked about with the PCOS discussion that I had before, or we had. Also looking at the cholesterol aspect and other aspects. We also look at the long-term effects that just carrying that weight has on all the organs, especially the orthopedic surgeons in the group see this on a regular basis, dealing with the wear and tear of the joints. Also, the dermatologists and primary care, since we do it on a regular basis, the skin friction and that aspect. So there's multiple aspects that go along with this. Next slide. So there's lots of different ways that we can look at body fat. We know the BMI, or the body mass index. We all know that it's our weight in kilograms divided by our height and meter squared. But the thing is, that doesn't really tell us anything. I have women that come in and have a normal BMI, but if I ain't see them really move, I'm wondering if they have any muscle mass. That doesn't mean they're healthy. I always say the gym rats or the muscle heads who are muscle bound, who have a higher BMI, but you can't see any fat. Does that mean they're unhealthy because of their BMI? So it has its limitations, so keep that in mind. We also can look at waist circumference, because as we're talking with the PCOS and more of the pear shape, if you're a typical female and have it more in the hips and the butt and your arms and your chest, that's not all that big of a risk factor. That's just kind of the genetics, and that's where your hormones have put the fat in a way. That's not the risky fat. It's more of the visceral fat that we have to worry about. And then also looking at the body percent fat. Next slide. So some categories of how to look at each group, from the essential fats all the way up to what fits into the obese category, for males and females. Keeping in mind there's some advantages. It helps us get a better idea of what portion is muscle versus fat, taking into consideration the essential organs in the muscle, because we don't want to get rid of that. We want to keep that and maintain the muscle. We also want to maintain that long term. But what's the disadvantages? Cost can be a factor. Insurance is not always paying for it. The difficulty, not everybody having these things. So there's multiple pros and cons of looking at this, but it's just a different way of doing it. Next slide. Waist circumference. We all can do that in the office. If we have a flexible tape measure, Sometimes you have to get the little bit bigger ones for some of the patients, but be able to do it. The advantage is we all can do it. The disadvantage is, do we do it in the right place or the same place, and are we getting the exact same numbers? And sometimes getting a little close to some of the patients, they don't want us to get close to them. Whoever's doing it doesn't want to get close to them. So there are some advantage and disadvantage, but that gives us a better idea of the more dangerous fat, at least a quick, easy way with looking at the visceral fat. Next slide. Kind of a breakdown for the BMI. We all know that now different ethnic groups will have different BMI standards, so keep that in mind. So if you see a group that from multiple different ethnic backgrounds, this is all based off Caucasian, so keep that in mind. So you have to have some flexibility. In Asian, the high end of the overweight to obese category is about 28.5, so versus the 30. So we have that flexibility, but it gives us a better idea of where we are. Most of my patients come in considering themselves overweight, even though their BMI is in the 40%. Sometimes we hate the word obesity because of the connotation that goes along with it. And part of it is when we discuss with the patient, ask what way is easy to, or better to talk about. Do we want to talk excessive fat? Do we want to talk about overweight? Do we want to use the word obesity, morbid obesity? So part of it is getting to know the patients and being comfortable with them and be able to talk to them about it in a comfortable setting, just like anything else. And there's some advantages and disadvantages of that. Next slide. So which is the best way to do it? Well, there's pros and cons to all of it. Depends on what you have the ability to do, what the patient will let you do, insurances, stuff like that. So just keep in mind there are advantages and disadvantages to all this. Next slide. So now we're looking at the adipose fat. Basically the fat, it's basically a system in and of itself. It has interactions affected by hormones, how it regulates things. As we talked about a little bit in the PCOS discussion about the insulin resistance, we're now starting to see that a lot more. Maybe is it because we're starting to look for it a lot more? Is it becoming more prevalent? Is it more of our diet aspect? Is it the stress levels? There's lots of different factors that are going in, being involved in that. But part of it is we have to be looking for and be suspicious of this, of when to discuss it with our patients, how to bring it up. The question is, what do we do about that? There are some just different responses that are going on in the adipose tissue. Next slide. Now this can be a little bit more specific to the gender. For the female, we had that discussion about PCOS and some of the things that go along with that. Having the elevated androgens, having the abnormal hair growth, the acne, the irregular periods, the weight gain, all that aspect, things we need to look at, looking for the acanthus nigricans, the skin tags, all those things can go along with the PCOS, but also can go along with obesity, and looking for these things and being suspicious of them. In the men, we're starting to see a lot more problems with testosterone. At least a lot of guys wanting to come into the office, well, I want my testosterone checked. Well, we want to check it, but, or at least have that discussion with them, let's put it that way. But what do we do about it? And weight loss can be part of it. Then we have a big long list off to the side of all the different types of cancers that we're starting to see more, that there can be some ties with obesity. Not saying obesity is causing these, but when we're seeing those and having a family history with obesity, maybe if we jump on it earlier, we might be able to slow down the progression of some of this problem. Next slide, please. Basically give us an idea of the multiple different factors that are going in, that are being involved with this. Having the metabolic aspect, the stress aspect, the increased body fat, different aspects and kind of different ways of looking at it. So keep that in mind. Next slide. A little bit more details on different tests. Kind of the gold standard to get a better idea is the DEXA scan. We use the same technology we do for bone density, but we kind of scan the whole body. We can break everything down into different categories, which is the bone, which we've had the good technology been able to do for a long time. what parts is the essential organs. We don't want to lose their brain, their heart, their lungs, the intestine, all the essential organs that we want to keep, maintain. What portion is muscle mass? That's the more important aspect. We also use it a little bit more. I know a lot of athletes will use it and to kind of make sure both sides are about as strong and about as dominant. But we can look at that. But then what percentage of fat and where is it? Is it more of the visceral fat? Is it more in one extremity versus the other? Is it something we need to work on? Is it something that we don't need to worry about? Next page. Looking at the nutritional aspect. Unfortunately, we always say, eat a good, healthy diet, exercise, and that's about as long as we spend on it. Keeping in mind that nutrition is a key aspect. We need to get back to the basics. And we had the slide earlier about the A to Z, looking at the 4 different types of diets and seeing some of that benefit of the low carbohydrate type diet. But part of it is that can be beneficial, evidence-based showing that, but part of it is what's their eating habits like? What is their ethnic background, their culture? What's their likes and dislikes? We have to take all that into consideration to kind of adjust and tweak things that'll work for them. We also want to look at the quality of the calories, not always the quantity. Everybody always comes in and says, okay, how many calories can I have? I'm going, I don't know. Well, why not? Because what is a calorie? A calorie is a unit of energy. How does your body use it? How effective is it? How active are you? So there's lots of different facts, not just a particular number. So keep that in mind. Next slide. Part of it is also a big factor is eating. Why do we eat? Is it because we're a society, you're at a meeting and there's food, which the food was very good this morning, I appreciate it. Is it because we're at a family party and everybody's eating? Are you eating because you just got off the phone with your significant other and something stressful is happening? Your parents are in the hospital? Or is it you're stressed because you have to take your board exam in a year? All these types of things. Why are you eating? If you're eating because you're hungry and to fuel your body, that's great. But if you're eating because of those other things, we need to deal with that. And unfortunately, actually it was kind of funny, in one discussion I had on one of the TV, I don't know if anybody saw it, the reporter asking me, or at least her comment to me was, well, I like to sleep as much, that way I'm not wanting to eat. It's like, well, maybe you shouldn't look at food that way. It should be that you're fueling your body. We don't stop it on a regular basis and fill up our cars. We wait till the light comes on or we get to a certain point before we put gas in our car. We need the same thing with our body. Remember why we're eating. Fueling your body, not just putting it in to try to deal with other issues. Next slide. Key aspect also is physical activity. Physical activity is always key, but if they hurt just walking into your office, they have a hard time standing up, me saying, go home and get on the treadmill for 30 minutes a day, it's not going to happen. Part of it is trying to get them feel better. If we can get some of the weight down through different options, they start losing weight, they start feeling better, they start getting out and doing something. Just another example, I had a patient come in who had started to lose some weight, and I go, how's your activity? He goes, it hasn't changed. And his wife goes, wait a minute, what do you mean it hasn't changed? This is the first time in the last 5 years you went out and shoveled the snow, and you are now out playing with the boys. So I take the approach at first, let them, when they start feeling better, most of them are going to start getting more active. They're going to start taking the stairs. They're going to be parking farther away. They're taking their kids or their grandkids to the park, going for a walk. So they're going to start incorporating this. If we start forcing, oh, you have to do exercise 30 minutes a day, they're not going to do it. They feel like, oh, they're failing if you're not doing what my doctor told me to. So keep that in mind. Studies have shown that it helps better with the maintenance of weight loss, not really with weight loss. So keep that in mind also. So incorporate that exercise a little bit more. I'm trying to get the body a little bit more with the exercise, our cells, more specifically the muscle cells, become more sensitive to the insulin. Therefore, it doesn't take as much insulin to do the function of getting the glucose, or at least one of the functions, to get the glucose into the cell so it can function. And it can also build up and use the energy that's there a little bit more effectively. Next slide. Part of it is also trying to incorporate more leisure activity. A lot of us, or at least most of our patients, statistically don't have a lot of leisure activity. So trying to incorporate that when they can. Talk to them about it. Unfortunately, we always put that as just a side note. Oh, we just need to increase more physical activity, and that's about it. Talking to them. Actually, with my patients, I will write a prescription. They like having go walking out of the office with a piece of paper saying, okay, this is what our goal by the next visit is. Going to incorporate this. Taking more stairs, walking farther. Maybe it is getting on the treadmill, but trying to incorporate that a little bit more. Unfortunately, we will focus more on that recommendation of the 30 minutes a day, 5 more days than not, so 5 days a week, type of a thing, that 150 minutes. But we're only focusing on that 30 minutes. Next slide. A lot of times we don't put a lot of emphasis on what we call NEAT, or the non-exercise activity thermogenesis. So basically incorporating, breaking up that, or excuse me, not incorporating, breaking up that sitting still. So standing up during a meeting, having the standing desk, even the desk on a treadmill type of a thing. If you're having a meeting, you can take it outside and go for a walk. I have some patients that, well, when they get a lot of phone calls, they'll stand up to take the phone call. Incorporating that on a regular basis. Unfortunately, we always focus on the getting the exercise. Sometimes we need to focus on the things that they can do on a more easier basis to increase that activity. Next slide. Kind of some list of why people want to avoid physical activity, from as it hurts, and nobody wants to do anything that hurts, to they don't like certain things, to they don't like to sweat. So talking about some different ideas of how you can incorporate that with them. Also getting them in the right environment, if the environment's not a good setting. If they live in an inner city where they don't, it's not safe, trying to arrange that, incorporating some of that exercise or some of that activity in their house. So just some advantages and disadvantages there. Next page. There are several medications out there, and there's some newer ones since 2012 that have been coming to the market, keeping in mind that we can use medications to help. But medications should be an aid to what we're doing, not, okay, here's your prescription, see you in a month, or we'll see you in 3 months. Part of it is we need to help the patient understand how and what's going on in their body and what they can do to change, to incorporate. Now, hopefully the medications will help. As we all know, medications have risk factors that go along with it. There's a lot less risk factors with changing some eating habits. Now, there are some issues with exercise, so we can keep that in mind. But medications are there to help us, not to be the mainstay. Okay, here you go, here's a medication type of a thing. And it talks about some of the advantages, the combinations that are now out there on the far side. And we'll use some other medications. These are the ones that have been FDA approved. We'll use some other medications that haven't been FDA approved but have shown some benefit. But keeping in mind that we need to remind patients if we're adding off-label type things, that we should at least discuss it with them. But we should discuss any medication with patients at any time. Next slide. Kind of a slide to kind of how do we go about this? Who do we need to worry about? When do we start worrying about it? Incorporating the idea of when do we get them into somebody who's specialized in obesity, or do we have to think about going straight to surgery? And there are some advantages and disadvantages of surgery, but nothing against the surgeons who are doing it. But if we can do something between going from the gym or one of the commercial grade programs out there to surgery. There's got to be something in between, and that's where focusing and working with our patients can help. Kind of gives us that direction of how to do it a little bit, and who to start and when to start. Next slide. Basically just gives us a little bit more information. It also incorporates the Edmonton obesity scale. This more with the orthopedic surgeons and more the function of it. So different ways of looking about how to grade or regulate and when to start these types of things. Next slide. This kind of gives us an idea, just the cost, but the effectiveness from going from a commercial grade plan or a commercial program, or going to the gym, or jumping all the way up to surgery. There's a lot that we can do in between, and that's where, as physicians, that we can help these patients understand what's going on in their body, how to function, what regulations, do we need medications, do we not use medications. But helping patients understand and looking at other problems. Yeah, they can jump up and have surgery, but if they have a binge eating disorder, or if they have night eating disorder or syndrome, or if they are dealing with a level or some stressful events, the surgery isn't going to fix that. So part of it is figuring out why do people eat and how do we attack it, and if we can't do anything about it, then look at surgery, because I have a few patients who, there's a lot of good data showing good results with weight loss, usually in about the first 6 to 8 months. Usually, statistically, they've seen a lot of decrease in the hormone ghrelin being released from the stomach, and that's one of the stimulators to eat, so they're not as hungry as much. But after that 6 to 8 months, that ghrelin level starts to increase again, and that hunger comes back. So if they haven't really been diligent in working on incorporating lifestyle changes a little bit, a lot of times they'll start eating a lot more. I have several patients and going, until you help me fix me up here, you can do every surgery you want down here. I had one patient goes, I know how to beat the system. So getting another surgery, making a smaller stomach, less absorption, isn't fixing me up here and helping with that. So we have to look at all that as the whole patient, not just a certain particular problem or a certain particular aspect of it. Next slide. Hopefully nobody takes offense, but I think we as providers are a key factor going, okay, just eat less, exercise more, I'll see you next time. Or here's a medication. Well, doctor, it says it'll cause weight gain. No, it won't. Or I'm gaining weight after you put me on that medication. No, it's because you're not doing it right. They look to us for some help. Medication, a lot of side effects can be weight gain, especially some of the psychiatric ones. So keeping that in mind, not saying we have to just worry about the obesity aspect. We have to treat their other problems too, but keeping both as a key aspect of what we're looking at and how to deal with patients. And try not to be the one that's saying, oh, well, and unfortunately we all kind of, at least in my experience, and I could be wrong, so correct me if I am, this seems to be the only medical problem out there that we actually blame the patient for. We don't blame them for having PCOS. We don't blame them for diabetes. We don't blame them for high blood pressure. We don't blame them for the osteoarthritis. We don't blame them for these things. We want to help them. We don't blame them for addictions. We want to help them. But when they come in and they're overweight, we go, well, this patient just eats too much and doesn't exercise enough. It could be. Don't get me wrong. A lot of them do that. But keep in mind, there are a lot of things going on, and that's what we want to do, is we want to help our patients try to figure out what is causing this, to change it if we can. If it's as simple as they're not eating enough, or they're not eating right and not exercising, great, let's incorporate that. But if it's not, let's do something else. Next slide. We want to try to incorporate with our patients, try to improve their life. Unfortunately, a lot of them think, okay, when I'm going to lose weight, I have to lose this 100 pounds. Studies have shown that if we can help our patients lose as little as 5%, somewhere between 5 and 10%, we're decreasing the risk of all the metabolic problems that are going on. We're going to decrease the risk of the cancers. We're going to slow the progression of their osteoarthritis. We're going to decrease these things, or at least slow it down. So if we can do that, that's what we want to do as physicians, because our goal is to help our patients be better and healthier, whatever the way that is. We also want to improve their quality of life. If they're seeing some success, they're feeling better, they're more energetic, that's what our goal is to help our patients be better. And to overall help with their body composition and slow some of this. Next slide. Now, we don't always have great success with everybody. These are kind of two case studies of mine. First one is a 62-year-old male who came in. As you can see, his obesity with a BMI of 53 with a weight of 404, with a history of prostate cancer, thyroid issues. We started doing some things after getting clearance from his urologist with all the surgeries and the bladder cancer he's had. We started getting him on medication, working on some eating habits, more of the right types of foods. We used some medications, and he started to lose weight. He got down to a BMI of 35. And 35 going, well, we need to do something about it. But we came down quite a bit from the 53. So part of it is we have to figure out where they've come from. And are we ever going to get any lower? Probably not. But he is doing a lot more. He's a lot more active. He's making better choices when it comes to eating. He's dealing with some stress and those types of things. And I think that's part of his issue right now, because he's now having some marital issues and admits that he's now not eating as best as he could. So we're trying to deal with that. Other example, an 18-year-old who has a family history of morbid obesity, with her mother already having gastric bypass, which had some complications. So the idea of doing surgery on her, at least from the mom's perspective, is no way, Jose. But we've tried multiple different medications. We've tried eating habits. We've tried dietitians. We've tried these things, and she continues to gain weight. Part of it is, sometimes I think I worry about the patients more than they do. So unfortunately, that's part of it, is we have to help them care about themselves also. So we see these things. Hopefully, from all this, with rambling about multiple different aspects, hopefully you understand that it's not just the calories in versus calories out. It's more of the type of calories, their sleeping habits, their depression issues, multiple aspects that go into their daily life. And hopefully we can do something about to help the growing, unfortunately, the growing problem. As we know, according to the CDC, the latest one, 70% of us would be considered in the overweight or the obese category by BMI standards, where 70 years, or not 70 years, back in the 1970s, only about 30%. So something's changed, and it can't be genetics. None of us changed that much in that shorter period of time. Hopefully we can get a better perspective of different things we can do, and hopefully I can help. If there's any questions, hope I can answer them. Guess not. Oh.
Specific diagnosis or standards for moderate exercise, miles per minute, number of stairs. Specifically, what is moderate exercise?
Moderate, well, part of it is you got to figure out what they can do. If they're in a lot of pain, they can't do anything. I try to find out what their ability to do, and let's push it a little bit. More into the mild, and let's push a little bit more. So everybody's a little bit different, so you can't go a certain amount of time. I try to find out where they're at, and then kind of find out where they want to get to. Some of us want to run marathons. Some of us want to be able to walk to the mailbox. Me training for an hour to go run for a marathon isn't going to help that person who just wants to walk to the mailbox. So part of it is help with that core strength, help them with it. And I focus a lot on core strength, because that's what's going to help them, especially a lot of these patients who are falling and having, or at least fear of falling. I try to incorporate that a little bit more, and trying to find out where they are and find out what their goals, and kind of gradually help them get that direction. So I don't have a particular number because everybody's different. Is that a non-answer? Any other questions that I can, yes?
Please go to the mic. Please go to the mic. This lady was next, right here.
Yeah.
One of the hesitations that I have found along with the older person and the weight loss is the fact that their insurance will not cover the plastic surgery that's required when they lose a lot of weight. So could you address that, please?
That is always a problem, but I always tell people, at least my answer is, we'll worry about that when we get to that point. We've got to lose the weight so we now can worry about that problem. It's like me telling somebody, well, why do I have to have my knee replaced or have a heart valve replacement down the road? You might not need it. You might just start losing a little bit of weight, and we might not have that problem. We'll use compression stock or compression clothing to help them with a little bit, but if that's their fear, I kind of help them with that aspect, because I try to get them over that fear of, okay, potentially I'm going to have that problem. Well, you might potentially, but you can't do anything until you get to that point. There are surgeons out there who are doing it to help them if we need to, and sometimes we have to search a little bit to find those surgeons that will help them. But part of it, if we can get those medical problems, and that's part of it, is documenting all the medical issues that go along with it to help that point. But, so I take that approach. There are surgeons out there, yeah. Mm-hmm.
Can you speak to your dietary recommendations, low fat versus low carb recommendations?
I use the recommendation of more of the low carbohydrate because most of my patients will fit into that, more of the insulin resistant. Well, why are they resistant? What's bumping the insulin up? Statistically, it's the carbohydrates. Now, part of it is, with going with a low carb, it's more of the refined carbohydrates. And unfortunately, if you eat a lot of processed food, the food companies are not out there to help us. Sugar can be listed under 56 different names in any type of food. So I try to teach my patients some of that, trying to go more of the low carbohydrate, healthy fat type component, because you can only eat so much fat and the healthier fats and incorporate that. But part of it is also looking at their lifestyle. If they're a vegetarian, me going, okay, you have to eat a moderate amount of protein, we focus on that. Where can we get the protein, different aspects of it. But I usually more of the low carbohydrate, the healthier fat type of idea, or higher fat component.
Question. We have a lot of patients that go to these weight loss clinics that are advertised in the newspaper, and they come back on, Armour and Metformin and all these herbs and things. What is your comment on that? Because my experience is they lose it, they always gain it back. So.
Exactly. That's always, and part of it is trying to understand what's helping them lose the weight. If the Metformin and the Armour thyroid is getting their body to function more appropriately, in my opinion, we keep using it. Is there risk for them? Yes. But if they're doing well, it's kind of like any other medication we put somebody on. There's risk if we put them on an ACE inhibitor. If they're doing well with it and they're not having any problems, do we take them off? So keep that in mind. If it's working, it's helping them, but hopefully with these different programs are helping them think about it. Now, people go, what about the meal replacement? Studies have shown that having meal replacements can help. It's helping control the number of calories. I look at it this way. Meal replacements is a good place to help people get started, but there's a lot of artificial stuff in there, so I'd like to get them back to real food. But how do we do that? Part of it is, especially the younger generation, haven't spent a lot of time in their kitchen and knowing how to cook and what to cook and how to do that. So some of that is trying to incorporate some of that. Now, is that my job to teach them how to cook? No. But looking for those different ways of trying to help incorporate having that healthier diet. What are their limitations? Is it because they're always in their go, or they just don't know how to cook? A lot of times we eat out because we don't know what to buy or what to eat. So, looks like any other questions? I'll be around for a little bit if there are questions.
Can
Oh,
I
one
just
more.
ask one more? I have a ton of patients that say, I just want a pill, or just give me a tapeworm. I don't agree with that. And my response is usually, no, you'd really need to kind of get on board with what you've already talked about today. But just in the interest of being accurate, when I tell them no, there's not anything up and coming, is there anything on the radar? I know it would sell wildly, but is there anything on the radar coming down the pike?
Nothing that I have heard of. They always say when you talk to the different companies, they always say, oh, we got something in the pipe, but nothing that's almost here that we can start looking for. Keeping in mind some of the medications that are there have shown some benefit. And when I put patients on medication, I said, the medication's there to help. We got to make the lifestyle changes to go along with it. If you're not willing to make the lifestyle changes, there's no reason to go on the medication and lose the weight. You might lose some fat. If we're not incorporating the exercise, odds are we're going to lose a little bit of muscle. You go off the medicine, now you still go back to your old eating habits. Now theoretically you're less healthy than you were because muscle doesn't come back all of a sudden just like the fat if you're not incorporating the exercise. So nothing down the pipe that I know of yet, but we're always looking for something because it's a growing problem. So if anybody has any great ideas, we'll take them. Thank you.